So good afternoon, everyone, and welcome to our virtual education program. My name is Shelby Riley, and I am the Education Coordinator at the Alzheimer's Society of Nova Scotia. We are excited to be able to connect with you and learn with you today. We are using Zoom for Healthcare, which is an online platform that helps us connect with you securely. So if you're experiencing any troubles throughout, please just send a message to the ASNS host, and we will try our best to help you get that all sorted out. For today's session, all participants have been muted and your videos have been turned off. With these privacy measures in place, we will be recording the session for further use. And before we begin, we would like to acknowledge that we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq Nation. We are all treaty people. The Alzheimer's Society is committed to undertaking work to create collaborative and respectful relationships. Together, our goal is to identify and develop tools that align with the beliefs and needs of Indigenous, African Nova Scotian, Acadian, and all equity-seeking communities across our province. We are committed to walk as community members in the elimination of racism and discrimination from across healthcare and society. Oops. At the Alzheimer's Society, we are working towards becoming a more diverse and inclusive organization where all Nova Scotians can feel a sense of belonging. So at the Alzheimer's Society, we use an acronym IDEA or IDEA, and this stands for Inclusion, Diversity, Equity, and Accessibility. And we use this to apply a person-centered lens to the work that we do to ensure that we're fostering a sense of belonging in all that we do. And to facilitate this work, we are very grateful to be collaborating with the organizations indicated on this slide. So you can take a look there. And I would like to say thank you again for joining in with us this afternoon. Our audience today includes people living with dementia, people caring for someone with dementia, and people who want to learn more. And so kind of the run of show, we'll have about 30 to 35 minutes of a presentation, and then we'll follow it up with about 15 minutes of a Q&A. So please feel free throughout the presentation if you want to send a chat addressed to the ASNS host of any questions that come up for you, and we will get to those at the end. Today's presentation is on being delirium aware. So delirium, an acute change in confusion, is a common condition that can affect older individuals with existing changes in cognition. It can be a medical emergency. So let's discuss recognizing delirium signs, what they mean, and what you can do about them. And so it is my pleasure to welcome and introduce Sam Searle, who is an assistant professor in the Division of Geriatric Medicine in the Department of Medicine at Dalhousie University. A product of Atlantic Canada, Dr. Searle trained at Dalhousie University, where he obtained his internal medicine residency in subspecialty in geriatric medicine. He is published on dementia and frailty and has a special interest in acute illness and the interplay of frailty. And so, without further ado, I will pass it along to you.
Thank you very much for that introduction. It's a pleasure to ally with the Alzheimer's Society to bring some more information out there. And I think this is quite relevant and important to really every older Nova Scotian or every older person who really ever gets sick, which is everybody at some point. So let's talk about being delirium aware. So we'll go to the next slide. And so these are the main things that I would hope we can discuss, and we can go over them and we can chat with them at the end. But what is delirium? How is delirium recognized? Delirium versus behavioral symptoms of dementia, which is different. And what should be done if delirium appears present? What do you need to do? So again, what is delirium? And so here I have This Is Not My Mom, which is a website we have created quite a while ago, but it's thisisnotmymom.ca, which highlights a lot of good information. We're in the process of updating it, but it still is quite accurate. And so delirium is a worsening of someone's mental state that really develops quickly, hours, days. And it's very akin to, acute brain failure. Um, and it's usually because there's an underlying new health issue going on with the individual who's sick. And it doesn't have to be something primarily related with their brain like a stroke. It could be a whole host of things that are seemingly unrelated. It's just something is medically going on with that person. And for some reason, instead of saying they have pain or they have other symptoms, they simply get some confusion. And what's interesting is it usually does improve when that issue is removed. And that's why it's important to recognize it, identify what's going on, to have that improvement. Next slide. And there's a few kind of global presentations of delirium. So delirium can sometimes be a heightened state. Sometimes people can be very agitated, aggressive. And this could fluctuate and they behave very unlike their usual self. At the same time, some people actually get hypoactive. So they get drowsy, they get tired, and they withdraw more. And it's almost like they're just sleeping all of the time at the most extreme situation. But of course, often we like to group things into categories, but oftentimes people can have a combination of either of these. And because this condition often causes this acute change in the mental status, it actually tends to over time fluctuate quite a bit. So sometimes people, even within a given hour, can become very drowsy to very agitated to very drowsy to very agitated. They're really not their usual selves. Next slide. And so, as you can imagine, there's actually quite a bit of symptoms and signs in terms of what it looks like. And I just want to kind of um, bring attention to some of these things because when we've looked at people who have developed delirium, most of the time, patients, care partners, family members do just the confusion itself doesn't lead to there's something going wrong. It's usually when there's a functional limitation with it. And we do know that if someone has this confusion and all of a sudden they're not able to do the things they're used to do, someone maybe could be have more trouble walking, more trouble getting to the bathroom, that actually is a sign that it may be a little bit more severe of a case of it. But it could be sleeping, less clear speaking, confused. Certainly when I see people who've presented with a delirium to the emergency department and they go home, oftentimes they're wondering if this was a TIA or if this was had a stroke and they're worked up for a stroke and then nothing ever ends up being found. So sometimes you can even have those neurological symptoms. And now who is at risk? And this is the general sense of who's at risk. So the older you are, or the more biologically old you are. So if you have a lot of health problems already, so multiple health problems, multiple medications, then you're more at risk for having this type of presentation. If you're having problems with your memory and thinking, the same thing is true. And what's important is the kind of older biologically, or the more problems you're having with your memory and thinking at baseline, it's actually the smaller it takes for someone to get some sort of injury such as this. So I've certainly see some people who are in the severe stage of their dementia or their Alzheimer's disease. And sometimes it's as simple as they didn't have a good sleep the night before, they're more constipated, or they just have been lying in their bed more so than normal. Sometimes a new caregiver can kind of spark that. It's also multiple health issues. If someone's had a previous delirium and a historical one, which is alcohol misuse. So if someone has a heavy history of alcohol in the past, they tend to have more common delirium and more dramatic delirium. Go to the next slide. And so the question is, you know, what are the causes? What are the contributors? And so it's important to note that if someone has a new delirium, so they're markedly different than they usually are, they could always have some memory problems, but they get some, they're dramatically different. They're not there themselves. This is very different. Their attention is very poor. Then it could be because of a medical illness. And this can range from any possible medical issue. So this could be pneumonia. This could be they're in heart failure. This could be their sugars are low. They've had a bleed. They've had a pain. They have um, uh, bowel obstruction. It could be any number of things. They could have had a stroke. And what's interesting is the individuals may not be able to communicate the usual symptoms that people have. For instance, for a pneumonia, they may not be able to communicate that um, they are delirious, or that they're short of breath, or they're having a cough. And the only symptom of that medical issue would be they're markedly different than their usual self from a thinking, communicating perspective. They're not their usual self. And this has been echoed in the literature multiple times, although it doesn't tend to get out in the general public, for instance. So, for instance, during COVID, there was a landmark study in the UK published, which basically showed that somewhere around 20% of people who are older and frail or have multiple health problems, when they presented with COVID-19, all that they had was confusion. All that they had was a delirium, without any of the other symptoms that we're kind of taught to be screened for. But it also could be medications, some medication changes. So the biggest contributors I see with that would be, to bring to the emergency part, we oftentimes would be medications for diabetes, kind of new medications that are bringing your sugars too low. But the other ones would be things that are sedating, sleeping medications. But really, any changes to to your existing medications, new or coming off some, can spark a delirium episode, or an episode of delirium. In some cases, if someone has a dramatic case of constipation, or if they're already in the later stages of their dementia illness, then something as simple as constipation or holding on to your urine for whatever reason in retention can cause something like this. And so, and it can be quite concerning, and really sometimes it's just we need to make sure that that person has a good bowel movement. Pain can be a contributor. And so sometimes people have lots of chronic pain or osteoarthritis, bone pain, or they've had a recent fall and they have more pain, and they're hesitant to take, their usual Tylenol or some creams to help soothe things, and that pain itself can cause a delirium episode. And so and that can be both in the community, but also in hospital. And it's not uncommon where I could go to, one of the intermediate care units, and I say, oh, actually, we just need to give them more morphine, more opioids, and more pain medications because they're in so much pain, and that's why they're more confused and delirious. And then dehydration, and sometimes even something as simple as poor sleep, can be one of the contributing factors. And you can imagine as well that a lot of individuals who have delirium, everything comes as a package. It's not like usually people have one thing wrong at a time. It's kind of everything builds on top of each other. So these all can be contributors for it. And so I think it's important to talk about this, not too much, but to a degree that if someone is experiencing delirium, it can be very terrifying for that individual, because that individual is an acute brain failure of sorts. And so that individual is having trouble figuring out what's going on with their environment and where they are, figuring out who's communicating, what's happening. And sometimes they can have hallucinations and odd thoughts and beliefs, seeing and hearing things. And so it can be it causes a lot of fear for individuals. They can feel under attack. They can have suspicion and these vivid hallucinations. And so that's why it's very important that when someone is delirious and you're approaching that person, to really be very calm and reassuring, because in the moment, this can cause a lot of issues. On the flip side, if you're a care partner, a family member, or a friend of someone who is experiencing delirium, the same thing can be true because there's not a lot of education on it. And oftentimes individuals think, oh, my loved one, my friend is um, not there anymore. They're gone and their 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 mind is gone. And what am I going to do? This is a new change. How am I going to help? This is permanent. And so really what is needed is really to address that with education from a healthcare team member or from us. Or for right now. Yeah, you can keep going. So Nova Scotia Health is growing in what they're trying to do for delirium. It's still not where I want it to be, but there are some ongoing quality projects that we're trying to work on. There's something called a patient attendant assessment, and so sometimes if there's someone who's in hospital, we actually have someone who will come and be company for someone who's delirious or prevent them from doing things that may be harmful to themselves or others. And we actually have a delirium assessment there. But that's really the only place we have kind of a standard delirium assessment for identifying it in hospital, other than everyone's clinical practice, which I think is something that everyone listening should be aware of and be empowered to recognize that if someone's not their usual self. I've already mentioned this is notmymom.ca. And then what we've been trying to do the last number of years is spread awareness of delirium, not necessarily to actually to patients and family, but to the healthcare providers, because sometimes because delirium in hospital is so common, sometimes you know it's almost normalized. So let's go to the next slide. And this is what I want to emphasize is that for the last 4 years, on one day a year, we screen everyone in hospital on delirium for delirium. And so that one day we'll go around and we'll ask every person who is in hospital screening questions to see whether or not they screen positive for having delirium. And consistently between 1 in 4 to 1 in 5 people on any given day in Nova Scotia is delirious. And so this is just the fact of the matter. And the question is, what can we do to improve upon this? But the first step really is to identify that delirium is affecting a lot of Nova Scotians who are in hospital. And not necessarily everyone who's delirious is coming to hospital. Next slide, please. So if you wanted to know kind of underneath the hood in terms of what we do, we use something called the 4AT, which is a 4-question thing, which takes very little time. And we just try to ask them, we see if they markedly are abnormal from their level of consciousness. So are they fighting, aggressive, agitated, or are they just not waking up very well? Then we ask them about orientation, where they are, what day is it, what year is it, what hospital, and we ask them to do an attention test. And that attention test can be anything, but in particular, we get them to try to list the months of the year in reverse order. Physicians and medical teams invent interesting things, but that's the attention test we do to see how well they're able to focus on this, because it can be a focus problem. And then we ask if there's been a change in the last 24 hours to a week. But that's not what I would necessarily recommend. Yeah, you can keep going. But that's not what I would necessarily recommend for everyone else, and certainly in the community. So there's 2 other ones. And so one's called the SQUID. It's the single question in delirium. And what that is a healthcare provider is supposed to do both of these. But I think it can be useful for people living with, if they have insight during the delirium episode, which they may not, or family members or care partners or friends. And that is this patient more confused than before? So asking that simple question, is this patient more confused than before? Not just a little blip, but like, is this person more confused than before? And then the next one, which I'm probably going to try to advocate continuing care start to utilize if they have capacity for it, is something called the FAM-CAM, which is basically 11 questions to ask patients or care partners and family members about the individual to see whether or not someone is potentially delirious at home, which can spark interventions to be done. Go to the next slide, please. Before we talk about what you can do to help with delirium, I just wanted to briefly talk about behavioral symptoms of dementia. And that behavioral symptoms of dementia and delirium are actually a very different thing. One is actually acute brain failure, and behavioral and psychological symptoms of dementia, or behavioral symptoms, um, is a result of chronic changes in the brain, and the individual's reaction to that and inability to communicate normally emotional needs, unmet physical needs, how they're trying to interact with the environment that they're interacting. And so these symptoms, which are really a talk on itself, um, are very common with individuals who have dementia, although they become more prominent at the later moderate to severe stages of dementia. Although earlier symptoms are these people still can have behavioral symptoms, but they're usually less obtrusive for people. But the typical thing for behavioral symptom of dementia is sundown. And so it's important to note that delirium will not behave the same way every day, will not have that same pattern. I do this and then they want to do this, or I do this and then this seems to happen, they act out this way. It would almost have no apparent rhyme or rhythm with respect to these changes. And it would be an acute change, and it would be persisting, and it really shouldn't go away, and it only should get worse unless there's certain things that are done. And that's why delirium can be a medical emergency, whereas some of these behavioral symptoms, there needs to be a lot of help and support, but they're not from potentially something like a serious pneumonia, serious bacterial infection, etc. But what's interesting, because delirium is kind of a symptom, it's someone who has acute brain failure. There's no particular medication for that. What we do is we actually treat the thing that's causing the problem. So we treat the pneumonia, we treat the infection, we treat the urinary tract infection, we treat the dehydration, we treat the constipation. And there's some simple, straightforward things that can be done for every person who has a delirium that can be really, really helpful to shorten the course of that, as well as prevent it from progressing to potentially a more severe version of it. And these things can be done in any healthcare environment, including even the intensive care unit, such that all these things are really important in any given environment. Let's go next. And so a lot of these things are also just good for just general good care for individuals who have a lot of health problems, or people that don't, but also people who have dementia. So as I mentioned before, there's a really, when this acute brain failure, there's really difficulty with understanding what's actually going on in that time. There's poor focus, can't figure some things out. So what we want to do is make sure that that individual has the best possible access and best ability to be able to interact with the environment. And we want to make sure that the body, that the mind is in its normal, usual routine, and there's not other things throwing it off. And so glasses and hearing aids on are really important, because you're not going to be able to communicate at all without having those if they do have that impairment, as best as you can. The other thing is, I mentioned there's a lot of fear that can happen with this. So reassure, reorient is very paramount. So when I see someone who has a delirium, I always introduce myself. I always I may even mention, even though I've seen them every single day, I may say, "Hi, I'm Dr. Searle. It's really nice to meet you. Um, I'm sorry if I'm intruding. I think we may have met before, but I'm not sure. Um, Again, it's nice to meet you. You're in X place. You're here because of this. You may find yourself to be a little off or confused. We're aware of that. It's because there's stuff going on, and we're trying to help you as best as we can." And so oftentimes I'll say something like that just to reassure them, even if I know them very well. My father was delirious with cancer in the hospital. He, I would come in and say, "Hi, it's Sam. It's your son, Sam. It's really nice to see you today. You're in the hospital." I would say that over and over again, even though, you should just know me. I'm his son, but it's really important to that otherwise. The other thing is to help the person move. So we do know that the more someone's moving, if someone's just lying in bed in the hospital, they're going to have more delirium. But if their body's engaged a little bit, it actually is going to help them. The only nuance with that would be if someone is end of life palliative, um, delirium becomes exceptionally prevalent, exceptionally common. And in that type of situation, um, it may not be actually helpful for that individual who's not going it's not going to be necessarily a reversible thing to move them. They may want to just focus on their comfort, and movement may not be in their best interest. That in mind, that still may be. And so that's just a nuanced approach there. Make sure we manage pain. Okay? So almost everyone I'll give scheduled Tylenol for, whether I think they have pain or not. But if someone has had that fall in the community, in their home, then make sure that they're getting a hot pad, maybe have a little bit of Tylenol, maybe some cream to help soothe that area, whatever. Eating or drinking, which is a bit of a frustration of mine, certainly in hospital, because we don't have a standard way of addressing this specifically to delirium. And that is, if someone is more confused, not oriented, they're really at risk for being dehydrated. And so keeping their fluids up is going to be exceptionally important. And keeping the nutrition adequate is important without forcing them, but trying to really ensure that they don't get dehydrated. It keeps coming back to the same thing, normal bowel, bladder, but we don't want people to be constipated. So making sure that they're having their regular usual routine and make sure they're not holding on to their urine. If they're not going to the bathroom, then the concern is whether at home or in hospital, again, this is very straightforward things, then the concern is that maybe they are dehydrated, that's why they're not peeing, or maybe their bladder's not working the right way, and they actually need to go check to see if there's not a process going on. And then optimizing sleep, which hospitals are notorious for providing poor sleep for people. Next slide, please. And so I really wanted just to touch on, just highlight a few things, because I think there's a lot of opportunities for advocacy for older people, or people who have memory and thinking issues, or people who have dementia, with respect to when they come to hospital. There is somewhat of a bias in Canada with respect to ageism, and because hospitals see so many people who are older who have memory and thinking problems, sometimes they really assume, or unconsciously, because their minds are going X, Y, and Z, that maybe um, memory problems are something that individual has had for a while. And so it's really important, if you're a care partner for someone who is presenting with what appears to be delirium or a change in their mental status that's quite dramatic, that you voice that opinion to the healthcare workers and say, "Hey, this is not my friend. This is not my dad. This is not my client. This is something different. This is what they're usually like. It's important that you know that, because this is different." And that's really helpful, because that helps the medical side of thing realize, oh geez, this is not their usual self. What is their usual self, and what are we looking for that's causing the problem? The same thing is somewhat said during hospitalization, because if someone does have a delirium and they're hospitalized, it's we don't know, or healthcare workers are unlikely to know that individual more than a care partner or a friend or a family member. And if that person has visited a few times in hospital, it's really, really helpful information when I chat with those individuals and say, hey, is so and so doing better from a thinking perspective? Are they less confused? Are they the same? Like 80% of what they usually are? How are they doing? Or are they dramatically worse? Because that means for me that, oh, my treatment's working, or my treatment's not working, or there's something else potentially going on. And sometimes we not may be able to um, appreciate that as well as a family member or a care partner. So advocacy is on the care partner, family, friend perspective is really, really needed and important. With respect to after hospital, so delirium, I said, is acute brain injury, which usually gets better after you've removed that triggering health issue. And that's true. It does usually get better. Sometimes it takes time. And so there's some studies out there that have shown it can take months for people to truly get back to a new baseline. And sometimes that new baseline is not their previous baseline from a thinking perspective. And that's why it's really important that we recognize delirium and we know if it's getting better or worse so that we can minimize the severity of that delirium episode so that it's less likely to have lasting effects in the long run. But coming back to the individual who's delirious, in an ideal world, if my patient was delirious, I would want them to be in their usual home environment, their usual processes, and have the hospital all there with them, helping navigate, making sure that the investigations can be done, the interventions can be done in a meaningful way. But that's not feasible. That's certainly it's not feasible, and so it's it would be great because that would be their usual environment. They'd have as many cues as possible to kind of reorient them and reassure them in that setting. But again, it's not necessarily going to be feasible or possible. So ideally, when delirium is identified, it's managed. Um, it's going to need to be fully optimized before someone's gone home, unless you have a very good appreciation for what caused it, and you can see that it's been getting better and better. Because then at that point, you really want to have them recuperating in an environment that's comfortable for them, bearing in mind that they still may have some new limitations that may improve. So you need to plan on that if they're still delirious going home, they're going to need a little extra help, a little extra time to recuperate in the short run to make it a sustainable time for home. As this is not always feasible, but there are always options. And it really takes a good, clear care plan to and understanding what the goals are to see what's actually feasible. Because if it doesn't work for the healthcare team, care partners in the community, then it's not going to work, period. Next slide. And so I just wanted to emphasize this one thing that came up in the news that I saw in 2020. This was a time for advocacy, which was there was someone who had a stroke in the valley, and when you read the document, he clearly was delirious. He ended up signing for um, um, a private room, and then he was discharged home, and then he was charged later. And his wife was like, he didn't even know who he was or what was going on at the time. How could he sign for a private room? This is really a failure of the health system. This, by the way, this is a common thing that happens not just in Nova Scotia. This happens across the country, across the world. I have similar stories from my colleagues across the pond as well about this. But still, this is an idea that we do have to advocate for this population because you'd expect that the hospital would be able to navigate around that, but this clearly was a gap in procedure, unfortunately. Next slide. And so these are just some expectations you should be aware of in hospital, and that if you're a patient or if you're a family member or a care partner, I know there's other um, people probably attending, but you know, if someone is going in for a surgery and they're at risk for delirium, you should actually be informed about that. So if you're older, if you have multiple health issues, delirium is a high possibility, and you should be informed about that. Everyone who comes into hospital or who has a surgery does have medications reviewed, but they should be reviewed with a specific eye to delirium. This is something that I find that we fail on, is that when someone is delirious, we actually need to inform patient and the care partners, ideally the care partners, that delirium is existing. And I think that will really help with a lot of fear and a lot of surprise, especially if this was a new thing that the care partner, loved one, family, friend was unaware of. Because I think that'll decrease a lot of anxiety, because the unknown is always the most scary. And then you should expect all the medical team members to be aware of the diagnosis. And the last thing is, it's going to be really important for family, friends, care partners to commute changes. And I keep harping that over and over again, but it's really valuable, really part of the team to getting a loved one better. Next slide. So just summarize a few things, and this is a taste of being delirium aware and a taste of some issues. And I hope people have taken some information away from this. So delirium is acute change in someone's mental status, and it fluctuates. It fluctuates, and it's an acute change, and it fluctuates over a given day, hour, days. I could see someone who has a somewhat of acute change, like, okay, let's just make sure they're drinking, eating, getting their medication, see if they have a good sleep, and if it continues to get worse, then that would make me concerned. It occurs because there's something new medical going on. And again, that new medical thing going on actually is quite broad. And some of those things are amenable to just, oh, they haven't been drinking for a while, let's get the fluids to them and just here, drink fluids and see how it goes. And it could be something as serious as a serious infection, stroke, heart attack. All delirium can be helped by a simple approach no matter the environment. And that was basically just optimize their understanding of their environment and make sure they're pee, poo, eating, drinking, sleeping in a way that they're used to and that's normal. Got to help their body stay a usual routine from that perspective while their mind figures it out. And then advocacy during delirium is really needed. And it's needed from everyone, from myself, it's needed for healthcare members, it's needed for patients and family members. Here's some resources. I put on thisisnotmymom.ca because I think it's fairly well put together. I didn't put it together. And then there's the Scottish Intercollegiate Guideline Network, and they have some really good family member and patient information on delirium. It's really well put together, and Scotland has a really strong world leadership with delirium. And I put also the Canadian Coalition of Seniors Mental Health, and there's some guidelines there. I put them on for BPSD because it's actually a separate issue, and they've got some also good non-healthcare provider information as well. And that's it. I ran it a little bit over. We started a little late, and I ran a little over than I'm supposed to do, but that's it. I'd love to answer questions.
Yes, thank you so much. This was a great presentation. I know that I learned a lot, so I can only imagine about everybody else. So without further ado, I will check the Q&A. All right. And if anybody had any questions they wanted answered, you can also send those over now. All right, so our first one is, what are the common misconceptions or myths about delirium, and how would you address them?
Yeah, so the most common myths or misconceptions about delirium is that it really depends on who we're talking about. So, from um, healthcare provider perspective, one of the commonest myths, this is not the patient or the family members, is that delirium is normal. And it's not normal. It's not normal to be confused. It's not normal to have a memory problem, and it's not normal for that to come on abruptly. And sometimes it may be expected, considering you know what that person's going through, but it's not normal. And so that's one thing. That's what I've been really trying to advocate a lot for from my side of the gurney, I suppose. From a family member patient perspective, the most the biggest kind of misconception is usually when you know a, um, a family member comes in during the hospitalization, and they've been coming in every day, and then overnight that person developed a delirium, and they come in and they see that person's not what they were like yesterday, completely different, and it can be really terrifying for that family member or friend, because they think that that person is dying, has lost their mind, and it's never going to get better or get worse. And but delirium is exceptionally common. It means that person's more unwell, and it means that stuff has to be addressed. And it can get better, as long as the inciting incident is something that is treatable and fixable.
Great, thank you. It's great to know that there's so many supports out there that people can access as well when they're experiencing these things. Our
Yeah,
next
I
question. Sure.
just to add on to that, I think we really need to beef up some of the primary care community resources with respect to delirium.
Mhm.
I think that is a bit lacking. It's lacking in the hospital, but certainly in the community, I think people need to be more empowered with understanding this than that they already have, and that's both healthcare workers and patients and families. So,
Absolutely. Absolutely. Our next question is, can you repeat the number of Nova Scotians experiencing delirium at any given time?
so I can't. I can give you some close numbers. So in hospital, I can say, and it's exceptionally more common in hospital. So in hospital, it's about 1 in 5 or 1 in 4. Um, and we've done that every year. 2 years ago it was 24%. The year before that it was 21% of Nova Scotians in hospital were delirious. That's going to be the highest proportion. It's been reported somewhere around, 6% of older adults in the community maybe have delirium. So 6 in 100 of older adults, like over the age of 65. Um, but it's going to fluctuate quite a bit. The problem is if someone has a delirium and it's not recognized, and it goes unrecognized. So they have done some studies where someone who has a delirium, who has come to the hospital or come to the emerge, and it wasn't recognized as a delirium at the time, although it was, and and uh, um, they were managed whatever, and then went home. People have very poor outcomes with that. It's very different than if someone has a delirium and people say, "Oh no, this is a delirium. It's because of X, Y, and Z. This is what we're going to do, and then that's the plan from here." This is when people who don't have it recognized for delirium, and people do really, really poorly um, um, very soon um, with respect to that. It's a lot. It's more common in long-term care just by the nature of that population. So I would I couldn't give you a number, but um, it would be there. Um, but again, it would be some subtle things necessarily could easily cause a delirium in that population. More dehydration, more constipation could actually trigger something. And then what you need to do is make sure they get fluid and make sure they're pooping.
Absolutely. No, thank you so much for providing that kind of estimate. And it's interesting to know that I guess we'll never really know the real answer to that.
Yeah, I mean, I think we can engage with that a little bit. But so I've been linking up a little bit with the EHS to try to get an understanding of how many of their individuals have delirium on their calls.
Mhm.
Um, and then um, I've had a few communications back and forth with continuing care slash VON with respect to the clients that they take care of and how they can kind of look at this and address this issue, especially since so many Nova Scotians don't have primary care physicians. We try to empower other people.
Wow, yeah. It's great to know that you're kind of having these partnerships, which is really great.
Oh,
Our
and that may
next
continue. But
our next question is what advice would you give family and caregivers who may be struggling with kind of the behavioral changes associated with delirium?
yeah, so um, if you're struggling with behavioral symptoms because of a delirium, you really need to get medical help, right? So if it is a delirium, so it's an acute change that is markedly different than they were before, that's a delirium and you need to get to the hospital. You need to call somebody up. You need to go to your family doctor soon to get that assessed. um, that's like period. Or talk to someone about it. I can see that there's what could appear to be overlap with behavioral and psychological symptoms of dementia. And I guess a first pass, if you're kind of like, well, this is a little bit different or not, I could see that a first pass of what I would recommend are those same things I recommended for a delirium in any type of environment. Make sure they're eating, make sure they're pooing, make sure they're peeing, make sure that they're going to have a good sleep. If they have a big change in their mobility, well, then you should call somebody up. If it's a little change, well, let's just keep an eye on it and go from there. But if they're having, you know, new kind of aggressive behavior or new behavioral symptoms that are to the point where it's very dramatic, then you should need to call to get some help and need to seek medical help. Um, and soon, after you do a conditional kind of like, oh, let's just play it by ear.
Absolutely. Thank you for that. We have another one, and so you emphasized the importance of having regular bowel movements. What would you say could help somebody who's struggling in this? So they mentioned that they have grab bars already installed, but they're struggling to explain why they aren't being able to have a proper bowel movement.
Okay, so I mean, um, so most of the time, if someone is delirious, they won't be able to self-recognize a lot of this. So it'd almost be somebody else that would have to note it, because just by the nature of that acute brain failure, it wouldn't be aware.
Mhm.
Constipation is exceptionally common as we get older. In fact, it's a very common thing for everyone as they get older. And with respect to that, um, it's obviously multifactorial. And one part of it is making sure people are drinking enough water. Another part is their diet, making sure that they're drinking enough water and having enough fiber in their diet. People tend to move less as you get older, um, sometimes. And if you're less mobile, that also makes people be more constipated. Um, and so there's really multiple ways to attack this. You know, nutrition, diet, fluid, fiber. And then the next step is, do we need to use any over-the-counter medications like a Restorelax sachet? It's also called PEG, or a Senecot. Another level is, okay, actually, a part of the problem is actually access and getting to it. And so if you're having trouble um, getting to the bathroom and using your bathroom functionally, then it's actually fairly important to ask for someone to do a community occupational therapy assessment, which is available to all Nova Scotians. It may take a bit of time, and that would be kind of a first step. Um, but with respect to bathrooms, it may be that you need um, a raised lift on your bathroom. on your toilet. And if that's so, then actually it's easier to get up and down off the toilet. The other thing is to make sure it's not cluttered as much as possible, but you know, most bathrooms are small and cluttered, so there's minimal things you can do. Um, um, yeah, it's hard to kind of say fully there, but that's kind of my overall approach. Diet, fluid, you can have a little bit of over-the-counter medications. If you can if you can keep moving, walking as much as possible, that will help. Yeah.
Great, thank you so much. And maybe we'll take one more, just looking at the time. This question says there's a situation with an older adult who's exhibited an inappropriate behavior towards maybe family members, and they're not sure if the behavior was out of character or not. Other health complications are present,
Yeah.
but no dementia has been diagnosed.
So it's hard for me to comment specifically on a certain medical cases, but what I can say is specifically with delirium is that it's not going to be just one person that's going to trigger such a behavior. It's going to be a persistent thing, and it's going to get worse. And so it wouldn't be that one person always causes that behavior going on. That's not delirium. That's not accurate. It could be a whole host of other potential things. Yeah, I could briefly say that there's one subset of dementia that is very difficult to differentiate delirium versus their usual self, and that's individuals who have a Lewy body dementia, which is less common, but that's again another talk for another day.
Yes, we could talk about this.
I could talk all day if you want.
Could talk about it for hours, I'm sure.
Yeah.
But with time, I guess we will move on. You were getting lots of thanks in the chat, I will say. And I would like to say thank you, Dr. Searle, for sharing your valuable insights with us on becoming delirium aware. And thank you everyone for tuning in today. You can send any comments or suggestions for next topics in the chat, or you can send them to our office, and you can use the number that's on your screen there. And you can also use...
I just happened to see one comment here. I wanted to quickly talk about it, which is urinary tract infections, yes, are common in older people. They can cause a delirium on its own. Get a urine culture, because a lot of the times people don't actually have a urinary tract infection, but they're treating for it, and it's actually missing the underlying issue. And oftentimes it can be just fluid. But yes, and it is common, but it's overcalled. Sorry. It's a pet peeve.
That's completely fine. Thank you for adding that in.
Yeah.
Absolutely. And just kind of saying the session has been recorded, and it will kind of be found on our YouTube channel in a few days. You will also get this if you signed up, and there will be a poll popping up on your screen. So if you just want to take a second to answer that poll, that would be lovely. Yeah, and we would like to thank you and wish you a great sunny day. I guess it's still very nice out there, hopefully wherever everybody is. And thank you, Dr. Searle, again.